everyone, and welcome to the Surgical Ergonomics podcast, where we will be discussing everything related to surgical and procedural ergonomics, the people, ideas, and technology that will help enhance your physical wellness and career longevity. I am your host, Geeta Lal. I'm an academic endocrine surgeon, speaker, consultant, and surgical ergonomics coach. Having experienced work-related musculoskeletal injury myself, I am committed to increasing awareness of and developing solutions to counteract the impact of poor ergonomics on the professional and personal lives of healthcare workers in procedural areas. On this episode of the Surgical Ergonomics podcast, it gives me great pleasure to have as our guest Dr. Andrew Gabrielson. Dr. Gabrielson is currently a chief resident at the James Buchanan Brady Urological Institute at Johns Hopkins University School of Medicine. He has a long-standing interest in surgical ergonomics and the study of work-related injury among physicians and surgeons. He's actually previously served on the board of directors and co-chaired the IT and Communications Committee of the Society of Surgical Ergonomics. By the way, the website that you see, the Society of Surgical Ergonomics, a lot of it is Andrew's work. So there you are. Dr. Gabrielson is actually next headed to Chicago for his fellowship in pediatric urology at Northwestern Lurie Children's Hospital. So a very, very warm welcome, Andrew, and welcome to the podcast.
Thank you so much for having me. It's a pleasure.
Great. So, Andrew, you were part of that core group that we started the Society of Surgical Ergonomics. So I know some of your story, but it would be great if you could tell our listeners a little bit about yourself, including where you grew up, how you ended up in urology and now pediatric urology. So some background and your current roles.
Yeah, sure. So I'm a California Bay Area native, actually.
Mm-hmm.
I did medical school in New Orleans at Tulane, Roll Wave. And then for the last 6 years or so, I've been at Johns Hopkins doing my urology residency. And, my interest in urology also kind of mirrors kind of why I wanted to go into pediatric urology as well, was that I liked taking care of a wide range of complex issues and kind of being the backstop of care for a certain specialty. So, I like that we kind of manage the purely medical to the purely surgical aspects of the work that we do. And then specifically within pediatrics, I obviously enjoy taking care of children, but I like to think of the peds folks as being kind of the Swiss Army knives of their urology specialties. You really have to be good at being able to do big, complex open surgery, robotic surgery, endoscopic surgery, microsurgical procedures. And it's fun because you're sometimes doing all of those sometimes in the same day. So everybody's a little bit different, a little bit, it's always a good time. And, the folks that I've been able to kind of brush shoulders with have been, taken me under their wing. They're a joy to be in the OR with. So, their love for the specialty also was infectious. So, in terms of kind of my interests, outside the hospital, most of my time is spent with my wife and our 6-month-old, who creates his own ergonomic challenges. We've also
Yes.
picking him up and out of the crib. I'm like, man, certain muscle groups that I feel like I didn't even know I had are suddenly being worked all the time. But in terms of, kind of how I got into surgical ergonomics as, as kind of a research academic interest, began when I was a med student. I was very active just with athletics. I swam and played water polo my whole life. And I was still playing in in med school. And so while I was a third-year med student, I actually tore my labrum in my shoulder. And at the time,
Wow, that's
I had no idea what
quite
that
an
was.
injury. Yeah.
And it's something that I nursed along for a long, 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 long time. And, rather than get checked out, I did kind of what a lot of trainees do, which is just work through it. I'm sure you
Not
have.
just trainees, all your attendings too, probably, I'm guessing. But definitely trainees. Yeah.
Yeah. And, I'm sure that, you can think of many examples, people that you've worked with, or maybe even you yourself had an injury, and it just felt like this is not the right time for me to address that. And that's essentially what I did. I nursed it through all of clerkships. And then even into my 4th year, I was having occasional shoulder dislocations for, months and months. And I just kind of worked through it. And what I found.
Can you just hold, can you
Yeah,
just hold there
sure.
for just one second? I'm sorry to interrupt you,
Yeah,
but I
please.
want to just repeat back to our listeners what you just said. I was not experiencing shoulder pain. I was experiencing repeated shoulder dislocations. And it was just not the right time to deal with it. And I just kept working through it. I think this says a lot about the culture in surgery and the culture in medicine in general, which is one of the things we try to address as part of the society. But I just wanted to point that out. Like someone outside of medicine and surgery would not understand what we're just talking about. All right,
Sure.
go ahead.
Yeah. And it really came to a head. I think I was in the ocean. I was on vacation or somewhere, and I was out in the ocean,
Mhm,
relaxing, and my shoulder dislocated again. And this time it really didn't go back in. And so it was basically
mhm,
kind of slowly swimming to shore, was an excruciating pain. And I was like, I need to get this checked out. I got an MRI, and eventually it showed the labrum tear. And when I saw the surgeon and speaking with him, he mentioned, I kind of heard through the grapevine that you are also interested in a surgical specialty. You're in medical school. How long has this been going on for? And I said, well, yeah, probably about a year, maybe more. And he's
mhm.
like, you need to have surgery like ASAP. Like this is not something that you can really sit on, which was sobering to hear. He was like,
Wow.
you may have a frozen shoulder. I can't tell you that that's not something that you may have a few years from now, maybe even right after surgery, because it's
Hmm.
it's a long-standing injury at this point.
Hmm. Hmm.
And so, went about, I got fixed, thankfully recovered well, did a lot of physical therapy and was able to work through it. But I think that it was that experience that I realized that this is not a unique experience, that, colleagues, people that I've worked with as a medical student and now in residency, a lot of them have
Hmm.
injuries like this, and they just kind of either nurse them along or kind of suffer behind closed doors. And in some cases, it leads to career-ending injuries, which can be devastating.
Right, right. Wow. So as I was listening to your story, something else struck me, right? So in the society and general work and talks and panels on surgical ergonomics, we talk about how when we finally experience symptoms that catch our attention and as surgeons, they often, second, third, fourth level compensations for injuries we've had for a long time. And it just, as you said, worked through, nursed through. And it's important for our listeners and others to hear as well that, we're humans. We have injuries both inside and outside the OR, activities that we do both outside the OR and inside the OR, ergonomic stressors. And that's why it's important to pay attention to both inside and outside the OR in terms of what we do to mitigate or reduce our risk of injury. To follow up on your last statement, though, Andrew, when you said, as spoke to people, I realized this is not an uncommon scenario. Now, you've been in training. Can you tell me something about the prevalence of work-related injuries among surgical trainees specifically?
Yeah, I mean, it's become a kind of a hot topic in the research realm, which is nice. So
Yeah.
people are starting to look at this within various specialties. Work-related injuries come in maybe many flavors. Some of them are this kind of acute insult. Some of them are chronic kind of overuse injuries. And then there's a lot of ones that are kind of, in between. You have things like needle sticks, which are, technically a work-related injury. You have workplace violence. You're
Yeah.
taking care of a patient and they're delirious, or they are agitated, and they
Hmm.
lash out at you, and there's definitely injuries of people that I know who have suffered injuries that way. But there is a lot of data out there now. I would say that
Hmm.
among trainees within the last year, it's usually measured within the last 12-month period, about 70 to 90%, 70 to 90% of trainees are complaining of some sort of musculoskeletal issue. Some of those are mild and they feel like they can work through it, but about 30-40% of them are moderate to severe. They feel like it limits some of their activities outside of the hospital, which is
Yeah.
kind of how that's usually defined.
Right. Wow. Those numbers are sobering, but and I'm just thinking back to when we looked at the numbers in our institution and pretty similar, about 80 some percent. Now, in these studies, do you notice that there's a difference between years of residence? Like, is it the senior residents that have been doing more cases, might be generally older, the ones that are having, or let's say fellows, or is it throughout the years of training that that's an issue?
There's this interesting inflection point that I think, there's some studies that show that as you get farther along in your training, the
Hmm.
rates of these injuries go down. But there are others where it goes up. And some of it's technique dependent. So you can
Yeah.
imagine people who are doing mostly open surgery and they're leaning over all day. There's a cumulative workload that kind of takes a toll on the body versus
Hmm.
some of the other ones, some of the studies that have been done in robotics, it actually shows that as you get more experienced, you learn how to adjust your ergonomics on the console chair, and more experienced people had less injuries. But I do think that there's an
Yeah.
inflection point with trainees where maybe the more junior residents are younger, maybe they're a little bit more spry, and maybe they have a little bit more, ability to kind of tolerate injury or like injurious forces on their body, but they also don't know how to protect themselves. They haven't spent enough time in the OR. They don't understand how to position their body. I still remember one of our attendings would always tell us you should never need to be throwing a backhand suture in general. If you position your body and just move your body to the other side of the table, you can always throw forehand, always. And I noticed that, just moving my body, sometimes in a very kind of exaggerated way, different parts of the procedure that used to be very taxing were not taxing at all. And so I think that some of the junior residents can have just as much injury, pain, musculoskeletal sequelae as some of the more senior residents. But the more senior residents are, suffering from kind of that cumulative workload and less
Right.
kind of posture, and it's flipped with the younger folks. So there's conflicting
Yeah.
feelings
Yeah.
there.
Well, certainly. Thanks for kind of laying out that literature. And I mean, I think even from what you described, it sounds like it's all through the years. It's not, there may be less or more, but it's not that the junior residents are exempt from these symptoms. And in some cases, they might be more exaggerated because of their lack of training and understanding of body mechanics while they operate.
Yeah.
So, given this data, what message would you like to say to our trainees who might be listening to this or other webinars or podcasts on this topic? I mean, why is it important that they need to pay attention to surgical or procedural ergonomics outside of what we've just discussed, which is the symptoms and work-related kind of injury?
Yeah, I mean, I think the major thing is longevity. There's a
Yeah.
workforce shortage for surgeons, and it's not going to get better, at least not in the next probably 20 or 30 years. And so I think that having good longevity of our workforce is important. And I think that that starts in training. Most of the habits that we learn, adopt, whether it's surgical techniques, whether it's body positioning, whether it's culture, whether it's kind of the ethos that you bring to the OR with how you interact with patients and how do you interact with other trainees, that a lot of it is cemented in training. And then once
Mhm.
we're out in the world, we kind of rely heavily on that training to then kind of branch out from there. So I do think that if you start with good habits early on in your training, in general, those are going to pay dividends in the long run. Now, it's hard to measure a lot of these things. So, how do you
Yeah.
measure one or two spot procedures that are really long when you're a junior resident and
Yeah.
long-term sequelae from injuries related to, some certain strain on areas? It's hard. I mean, I think that we're just starting to scratch the surface with occupational health data, which may actually give us more info on that. But I think the main thing is longevity. And then the other thing is that this is a space that I think is ripe for innovation. I think that
Yeah.
within the next 10 years, I know that a lot of this was mentioned at our recent SSE meeting. I can anticipate there being changes with how devices are designed, certain
Mhm.
adjunct equipment like the exoskeletons and things like that. I can see these becoming adopted into the OR. And if there are kind of people who are interested in being kind of the lead on some of these things, this is also an opportunity for
Mhm.
folks to kind of, dive in head first and make a real impact.
Yeah, all good reasons for people to think about their ergonomics, not just for their personal physical well-being and career longevity and sustainability, as you pointed out, but the greater good of our society because we're facing problems with access to surgical care and surgeons dropping out of the workforce because they're getting injured is not going to help that situation. And, I think you might have read this and noticed this as well, but there's definitely a correlation between our physical symptoms and mental well-being. There's a lot of attention paid to mental well-being. and now increasingly attention paid to physical well-being, but they go hand in hand, right? They're not mutually exclusive. Would you agree with that?
Yeah. I feel like when I've given a couple of kind of grand rounds lectures, talked to
Yeah.
colleagues here, and most people think of ergonomics, they just think of physical ergonomics. They just think of
Yeah.
posture. Oh, ergonomics. That's how
Yeah.
just sit up straight. That's it.
Hmm.
But the cognitive ergonomics, organizational ergonomics is its own thing.
Yeah.
That cognitive workload is something that is less tangible, so people don't think about it. But I think it can be more insidious. I think
Yeah.
things like flow disruptions in our OR, things that kind of
Hmm.
impede our efficiency, they don't seem like it's a big deal, especially early on in the day. We've had our coffee, we're feeling good, we're moving along. A stitch is not available for us. We have to wait a minute or two. No big deal. But when it's 4 o'clock, 5 o'clock, the teams are starting to switch over. You may not have your A team in the room anymore. And then
Hmm.
suddenly those little paper cuts they start to snowball. And then suddenly you're
Yeah.
hour, 2 hours, 3 hours behind on cases. And it can be really stressful, for the
Yep.
student.
Yep.
You're having to talk to the family. Why is everything going so, why are we behind? Is my child okay? Those things add up. So I do think that the cognitive aspect of things is often.
Yeah. I'm glad you brought that up, and I want our listeners to know that I'm already planning a session in this podcast on cognitive ergonomics from our resident cognitive ergonomics expert in the society, Dr. Tara Cohen. So more to come on that down the road. I agree with you, and I think the cognitive ergonomics piece actually contributes to our susceptibility to physical injuries as well. The workload aspect, as you mentioned. Now, Andrew, in the last little bit, you brought up an interesting point. We've touched on this a little bit, the culture of surgery. And whenever I'm giving talks or doing workshop for residents, and we talk about best practices, well, there are a couple of things. The residents want to know, well, we don't have formal ergonomics training. Last time I looked, it was less than 5%. Maybe now it's about 15% of programs have formal cognitive ergonomics training. So that how do I go about getting this training or information about best practices? How can we make that happen in our training program? And the second and related question I get from trainees is, it's great. You're telling me all these practices and information where to find it, but I don't feel comfortable asking my attending to bring the height of the table up to where I want. And I'm often standing this way and that way and basically digging a hole in the ground with my feet far apart because the attending is shorter than me. How do I approach that? So I often tell them what I would do and how I think they should approach that. But given your expertise in ergonomics and the work we've been doing, as well as your being kind of a mid-level resident and now a senior resident, now will be a fellow and attending soon, I'd like to hear what advice you would give to the trainees in this scenario. I'm sure they'd want to hear too.
I mean, that I think is a major barrier to implementation. But I think it's
Mhm.
some of it I think is a perceived barrier. I guess I'll answer your first question. In terms of resources of finding best practices, there are a couple
Mhm.
freely available resources that I think are wonderful. The American College of Surgeons has a surgical ergonomics guidelines that they published a year or two ago that has
Mhm.
nice pictures and is pretty easy to follow. Dr. Sue Hallbeck, who you will have on this podcast as well, also has
Mhm.
published several chapters that have really nice images, make it very kind of straightforward for someone to just quickly look at the figure and be like, I understand what neutral body
Mhm.
position looks like. And, if you
Mhm.
want it to be very technical about it, you can look at different angles of different body parts. There was also a nice recent review in American Journal of Surgery, also by Dr. Hallbeck, that I think is worth looking at. And then there's been a bunch of kind of primers that have been put out there, various surgical specialties. I know plastic surgery has one. Our team here wrote one for urologists. They
Mhm.
are out there. And so I think that some of those are very helpful because the ergonomics that make sense for a urologist are not necessarily always applicable to that of a plastic surgeon, for instance, or an otolaryngologist or a thyroid surgeon.
Absolutely.
So I do think that there's a lot of resources out there many of them are freely available and certainly available through, an academic library. But how do we implement it? I think that that is kind of the age-old question, and
Mhm.
maybe I've been very fortunate here with the people that I've worked with, but most of our attending surgeons have actually been very open to making modifications to the OR, and some of them actually encourage and are kind of prompting us to optimize the layout to be a little bit more friendly on our bodies. Table height, monitor position, things like that. Those are things that you can think about as a trainee going into a procedure. A lot of times you're bringing the patient in, or anesthesia brings the patient in, and you're there kind of waiting to prep. That is a perfect time while you're waiting for anesthesia to put the patient to sleep to rearrange some of the room a little bit to kind of get it set up for yourself so that when you're draped and ready to go, you're not asking, a circulator or a scrub tech to come over and do that for you. Another option, which is now I know that you are also involved in this initiative,
Yeah.
but is
Yeah.
looking to kind of incorporate really basic elements of ergonomics into this surgical timeout, or at least run in parallel with existing kind of checklist workflows.
Yeah.
I feel like that is a great opportunity to democratize discussing ergonomics and just making it something that whether you're an attending or a resident, fellow, circulator, anyone who's in the room, it kind of normalizes discussions about these factors. And so, I'm excited to see, how this work develops and piloting, kind of creating this ergonomics timeout. But I think that that's really exciting.
No, I agree with you. Just to clarify for our listeners, what Andrew is referring to is something that is going to be led by Dr. Julie Haley, who's the current president of the SSE, and we're looking to develop a formal ergonomics timeout using Delphi methodology, right? And when that sort of international collaborations work comes out, it's pretty straightforward if you can look at the best practices, and I'll include some of the I'll include the references that Andrew has provided, as well as the ones he's mentioned, the American College of Surgeons ergonomic recommendations. The Society of Surgical Ergonomics website has some of the photos, and the article from Dr. Hallbeck's group, the American Journal of Surgery article. And in fact, for those of you who are in general surgery, vascular surgery, bariatric surgery, etc., the SCORE curriculum that is used by most general surgery residents for their basic surgical training junior years has actually it's an optional module, but there is a module on the basics of surgical ergonomics. And if you can just incorporate those techniques, as you said, in that initial timeout, it's a great way to make it sort of nothing special, but just standard operating procedure, just like we do surgical safety checklists, right? It shouldn't be something special. It's fascinating to hear you say sometimes it's a perceived barrier. And the reason I say fascinating is because that's the exact response I've given to residents when I've been asked this question, is that, have you ever asked? Because if you asked your attending, I would contend that, most of them, I can't put a number on it, but most of them would say, oh, sure. And there might be some barriers in terms of the level of residents. I think senior residents, having spent more time in the program with the residents, feel comfortable asking. But I don't have a randomized controlled study, but I had a workshop with residents and attendings, and I asked this question, and the residents actually said, well, we've never asked because, that hierarchy. And I asked the attendings the same. I said, has anyone ever asked you? And they're like, no. If someone asked, what would you say? Almost all of them, at least in that workshop, and it's hard to know because the residents were there, but they were like, if someone asked me, I would consider it. So it is, I think, as you say, some of it is perceived barrier. And I tell the residents, always ask, what's the worst that'll happen? You'll be no better than you are right now, right? So just ask. Might be better. You maybe don't have to push yourself into the ground to accommodate an attending that's shorter than you.
I feel like that is such a natural response, though, as a trainee,
Yeah.
is that we just
Yeah.
want to be deferential to the attendings. And
Right.
that's something that
Right.
existed forever. And so, I mean, there was a procedure recently that the monitor that I needed to see to, do the procedure is
Hmm.
off to the side. It's kind of half facing me. And my
Hmm.
natural response is not let me ask someone to reposition that monitor because it was easily viewable by our attending is that no, let me move forward, watch this. I can actually do the case very well and safely without needing to adjust the screen, which is completely ridiculous. I mean, and that's the fact that that's the natural reaction also goes to show that this is something that we're going to have to work on, just
Yeah.
snap out of.
Yeah. The culture is so ingrained that we don't even think about it. as you said, right? It's just, but then on the flip side, I like to think that, well, we're the ones that made this culture, so we're the ones that can drive the change of the culture, right? No one from the outside is going to be able to do it,
Yeah.
right? We're the ones that have to do it. But fascinating that you had the same perspective on that, that it's a perceived, probably a perceived barrier. So, since you mentioned, obviously there are general tips, but then there are going to be differences in specialty. And since we have you as an expert in ergonomics and also a urologist, I was wondering if you could give our listeners who happen to be in urology some tips and tricks that they can immediately start paying attention to today as just after this podcast episode and start to make some tangible changes in their setup, etc. So what are the things they should be thinking about?
Yeah, so in urology, we do a lot of endoscopic procedures,
Hmm.
but our entry point is typically the urethra. And
Yeah.
so rather than being kind of at the level of the patient's abdomen, a lot of the work that we are doing is kind of relevant to our entry point, which is the urethra. So, something that's very kind of easy to implement if you're doing endoscopic procedures within urology is setting the table height so that your entry point, whether that's the urethra, whether it's through the flank, through a sheath, an access sheath into the kidney, is to place that entry point at roughly the pubic symphysis if you are standing to operate, which most of us do. I
Hmm.
think that that's just an easy kind of rule of thumb when you're getting the case started. You're usually asking for some of the circulators to plug in your various scopes, and you are staring at the patient, and you can basically look with your scope at your pubic symphysis and point it straight out. And if the entry point into the patient is not there, adjust accordingly. It takes about 2 seconds, and the entire case feels a lot easier. Monitor positioning, I think, is also something that's just so easy to address. Typically, we recommend having the monitor being about 3 to 4 feet away from the viewer, and then kind of as directly in front of and eye at the horizontal level as the surgeon as
Hmm.
possible. And sometimes that's hard to do. Sometimes the room doesn't kind of allow that, but there are some placards that you could simply put over the monitor to say, please position me in front of the surgeon about 3 to 4 feet away. And then you can flip over this placard and start the procedure. Things like that are low budget. You could easily put that in some of your ORs.
Hmm.
And that's just a way to make sure that when you start the case, you're set up for success. Trying to think of what are some other things that are easy. We wear lead a lot. We wear lead
Hmm.
aprons. Some of those can be quite heavy. And so, we're usually in a rush. We're just throwing the lead on. We don't actually, put all the fasteners to try and, adhere it to our body. But I would recommend taking the extra second to put on the waistband, clip everything in. They're there for a reason. In general, most of the lead that we wear, which is full body, if you have that waist strap properly tightened, it's going to offload a lot of the tension off your shoulders and it's going to be placing it on the pelvic brim, which is where it should be. If you've ever gone backpacking and you wear a backpacking backpack, you have a waistband. It's not just there for show or for fun. It has a very specific purpose, which is to offload most of the
Yep.
weight onto your pelvis. Trying to think of what else. Yeah, I mean,
Yeah,
there's so many kind of little nitty grit things you could talk about, but those are a couple things for endoscopic procedures that I can think of.
definitely. And I want our, listeners to understand that these things that Andrew just shared are absolute gold. Okay. So just taking that few minutes, I know it doesn't seem like much. Oh, it's a short cysto. I'm just gonna, wear the lead this way and just kind of do this. But just think about how many cystos you do in a week on a particular day. You're usually doing them back to back. Add that, how many 40 some weeks a year, multiplied by how many years, which is why there's a peak of injury reporting among surgeons in their mid to late 40s, because or even if you don't have that age group, it's usually 10 to 15 years in practice, right? Most of us come into practice in our mid 30s, right? So it's about early to mid 30s. So that's the time frame. And it's because it's a repetitive force injury. One other thing I wanted to ask you about with aprons, obviously, if they're single piece, having that belt, helps. But if they're double, two-piece aprons, are those supposed to be better or are they about the same?
There's some literature, I've actually looked at this. There's some
Yeah.
literature for among techs and people that are working in
Hmm.
cath labs, and
Yeah.
do suggest that the two-piece may be a little bit more favorable because by definition, those people have to
Yeah.
put the bottom around
Distribute the
the pelvic.
load. Yeah.
Yeah, they have to put it on the
Mm.
pelvic brim because otherwise you're going to be pantsless. But the one piece sets I think are just as good as long as you are
Yeah.
using that waist cinch. The
Yeah.
problem is I can think of some of the lead that we have on our trees right now. They are one piece lead, but that really nice waistband is not connected to it
Mm.
and is in the ether somewhere. And so, you don't have
Right.
another lead. You just kind of throw it on and just kind of suffer through the case. But as you
Yeah.
said, I mean, these are all small paper cuts sometimes, and they can lead to some pretty bad outcomes.
Now, as a pediatric urologist in the future, I anticipate you will be using a lot more loops than you do now. I suspect the urologists use loops now for ureters and maybe transplants and things like that. As someone whose neck damage is probably a lot of it is from loops, among other habits, I wonder if you can, advise our urology colleagues about your thoughts on loops.
Yeah. So the good news and bad news is that there
Yeah.
isn't a perfect loop for urology, especially as a trainee, because you're doing some procedures where you're in the perineum and you almost want your loops to be the declination angle, as we talked about, to be
Mm.
minimized. You want to be looking almost straight
Yep.
forward with our loops. On the other hand, we may be doing surgery deep in the pelvis, and we want to maximize that declination angle so that we can be as upright as possible and still be seeing our target anatomy down in the pelvis. So as a trainee, you kind of can't win as a urologist, but in general, as people move on into their career, they're going to specialize in something that is probably only going to necessitate one kind of style of loop, or at least one declination angle of loop. We've kind of talked about this before at the SSE meetings and things like that. We've had some really good talks on loops. But in general, I would say for a urologist, I would say get a loop that has a fairly steep declination angle, because I
Mm.
think that that's where you're going to get the most bang for your buck for most cases that we do where you need loops. The perineal work, you can still use those loops even with a steep declination angle, but in theory, the anatomy is quite close to your face. And so if you're going to take a hit on any operative approach, I would say
Yeah.
that perineal work, you may be able to do okay without loops. But
Yeah.
find the lightest frames. I think all of these vendors, they're kind of variations on a theme, but where I
Yeah.
think you can really make an impact is find the lightest loops. They are going to weigh on the order of grams, but some of them are, anywhere from 30 to 50% lighter than the others. And as you mentioned, these are chronic overuse injuries that we're talking about. If you wear it all day, every day for many, many years,
Yeah.
30% difference in weight can make a huge difference.
Indeed. Well, Andrew, I think we're winding down to the last bit of our time. And as we do that, I wanted to ask if you had some piece of advice, like the one thing you wish you knew before you went down your journey, and what is the one thing you would like trainees in particular to know about ergonomics before we close?
We've kind of alluded to it earlier in the episode, but I would
Okay.
say being willing to be a little bit outside your comfort zone to make your body comfortable. I think that can be daunting, especially when you're a junior resident, to say, hey, can we change the table height or can we do the monitor location, things like that. I used to think that that would be a big deal, and now I realize that almost no one cares about it. And in fact, most people have the
Wow.
mindset on other things. And so they have no problem with you changing these minute, elements of the OR to make it more comfortable for you. They are more focused on the procedure at hand. So I think don't be afraid to try and make changes, to try things. Recently in the OR, I said, let's do some of these intraoperative stretches with our team, and kind of was like, I don't really know. It might be a mixed response. Everyone was completely into it. They were like, let's do it during the next case. Let's do it.
Okay.
We should be doing this frequently. And now there's micro breaks, placards that are out in the peds ORs. And so I think that, don't be afraid to suggest things, because you'd be surprised how many people are on board as well.
I love it. I love it. So the residents listening to this, the trainees at any level listening to this, you heard it here first. Residents can and do have the power to effect change. You are the attendings of tomorrow. I've often said this, Andrew, you've heard me say this. In one generation, we won't be thinking about, should I ask if I can have the table up or not? It will be standard operating procedure, hopefully, once we get that checklist out just like the WHO checklist came out and suddenly it was not a big deal to do it, you know.
Yeah.
That brings us to the end of our time. And again, Dr. Gabrielson, thank you very, very much for your time and expertise and being so deeply involved and passionate about surgical ergonomics, not just from your own perspective, but also to improve the lives of people around you, your colleagues, and with the Society of Surgical Ergonomics work as well. We all feel that you've got great things in store for you in the future, and we're looking forward to seeing your career trajectory and see how things turn out for you. We're all rooting for you and very proud of you. So with that, I'd like to end this episode, and we hope to see everyone on another one another time.
Thank you so much for the kind words and for having me. This was awesome.
Please remember to subscribe to the podcast and follow us on social media, Instagram, X, Facebook, and LinkedIn. We love feedback, so please reach out to us for topics, ideas, speakers, or if you ever want to be a guest on the show. Thank you for listening.